Good afternoon. My name is Michelle Prado, and today I will be walking you through my senior design team's development of a therapeutic exoskeleton for pediatric patients with hand weakness. Our client for this project was Ms. Karen McCormick, an orthopedic therapist and hand therapist at Children's of Alabama here in Birmingham. Her patients include pediatric patients ranging in ages 2 months old to 21 years old with hand weakness and or limited mobility. There are two overarching causes of hand weakness in pediatric patients and elderly alike. The first is neurological. This occurs when the electrical signals traveling from the brain to the muscles are somehow disrupted, causing weakness. Then there are physical causes. This could include muscle atrophy, trauma, or congenital deformities. The primary causes of hand weakness in pediatric patients include congenital deformities, missing digits or limbs, cerebral palsy, weakness on one side, transverse myelitis, and Guillain-Barré syndrome. In order to fully understand the clinical need, we first explored the existing solutions. On the far left, you can see an example of a gripping aid. These generally allow users to hold objects like utensils, pencils, and toothbrushes without conforming the hand into a rigid position. Then there are gloves. Gloves more so conform the hand into a rigid position, but allow users to hold heavier objects without worry of dropping them. Finally, there are robotic hand actuators. These are more complex in their construction and include both mechanical and electrical components and are more so for precise control of the hand. Some of the limitations of existing solutions are as follows. They all almost exclusively are sized for adult hands. This results in them not being the appropriate size for small, still developing hands, such as those of pediatric patients with hand weakness. Additionally, they can weigh too much for a still developing child with muscle weakness to take full advantage of. And finally, they're almost always either assistive or therapeutic and do not contribute to patient care in both aspects. Based on the limitations of the existing solutions, as well as the general needs of pediatric patients with hand weakness, we developed the following needs statement. A way to both exercise and assist the hands of pediatric patients both in the outpatient setting and at home that will increase both grip and pinch hand strength and enable pediatric patients to be more independent from caregivers by helping them perform tasks they would otherwise be unable to do. From the clinical needs statement, as well as additional meetings with our client, the following list of major design constraints was developed. To assist and or exercise pinch grip, to assist and or exercise gross grip, be sized for the hands of pediatric patients, maintain tactile sensation, be child-friendly and durable, allow for integration into activities of daily living, be portable, and finally, follow appropriate federal standards regarding performance and safety, risk and comfortability, and software management. With these design constraints in mind, we entered a period of ideation and brainstorming from which 3 primary designs emerged. There was a tablet game, which would include stimulating games that would allow patients to exercise their pinch and finger movements, a VR hand controller with switches on each finger that would act as controller buttons, and glove that could be used to play games like Guitar Hero. Finally, there was an assistive exoskeleton with cables along the back of the finger controlled by motors that would generate compressive and tension forces to open and close the hand. After much deliberation, as well as using methods such as pew tables, the assistive exoskeleton was selected for further design development. With the assistive exoskeleton design selected for further development, its overall design was divided into 2 subsystems, the mechanical subsystem and the electrical subsystem. The mechanical design is currently the 3rd revision after analyzing the limitations after each iteration. It features a mechanical linkage finger that is actuated by a lead screw on the back of the hand, With each turn of the lead screw, the flange nut, shown in gold on the lead screw, translates, and the cables connected to the anchor points on the finger change length. The third linkage design fixes most of the limitations found in previous iterations of the design. Firstly, it solves the issue of incorrect proportions and features internal linkage beams that do not extend outside of the finger geometry when contracting. It also mitigates the problem of complexity in that it uses fewer total parts, and each of the parts serves multiple purposes. Then there's the electrical subsystem. The mechanical components will be driven by several motors that will be controlled by the circuit seen on the left. We plan to use proportional integral derivative algorithm to control the motion of the gear motors dependent on the flex sensor's output values. Using PID algorithm greatly increases the accuracy of the movement. The proportional portion of the algorithm allows the system to recover from a change in the reference value, in our case the flex sensors. The integral portion of the algorithm eliminates steady state error by decreasing settling time and increasing the overshoot. The last portion, the derivative portion, smooths out the response by decreasing overshoot and increasing the settling time. Each component of a PID signal is shown in the figure on the right. In order to answer the question, how does this design resolve the clinical needs statement, each design constraint was reviewed and assessed as to whether or not it was addressed by our solution. The results of these assessments can be seen in the figure below. The section at the top right portion of our poster, entitled Current Prototype versus Marketable Design, is meant to highlight that in addition to developing this prototype, exploring the business and market for such a solution has been a large part of this project. To better explore these, a marketable design has been developed concurrently with the prototype. There are several distinct differences between the prototype and the marketable design we've been developing. First is linkage material. The prototype uses 3D printed PLA, but we plan to use lightweight aluminum in the final marketable design. Then there are the features. The prototype acts only in an assistive capacity, but the marketable design will include an assistive mode and a therapeutic mode to hit both the assistive and therapeutic/exercise needs in the design constraints. Additionally, user information is a key difference. The prototype does not have an ability to store user information, but the marketable design will include an SD card to store and track the use of the therapeutic mode by patients. To summarize our product, this semester and last semester has been spent developing a solution to the lack of assistive and therapeutic devices available for pediatric patients with hand weakness. This process of developing the solution can be broken down into the following primary steps: identification of the patients and various causes of hand weakness, exploration of the existing products and devices that exist as well as their limitations, development of a comprehensive need statement, identification of major design constraints necessary to resolve the clinical need, brainstorming of possible solutions, and selection of a design idea to pursue, breaking down of the selected idea into major subsystems, and detailing their individual components, and finally, summarizing how the prototype design fulfills the design constraints. Additionally, we'd like to recognize our client, Ms. Karen McCormick, for our identification of the clinical need as well as her expertise on the patients in anatomy which are impacted by conditions causing hand weakness. We'd also like to recognize Dr. Eberhardt and Dr. Feldman from the Biomedical Engineering Department, who were integral in the development of our design as they acted as mentors and guides throughout the process. Finally, we'd like to recognize Justin Cook for his machining expertise and input regarding our design. Thank you for taking the time to listen to and review our poster presentation.